So welcome to everybody. I'm sure I'm not seeing everyone, but so glad you're here. So I have the great pleasure today of introducing our two speakers. They probably are familiar to some of you, many of you. Our first speaker is Dr. Sandy Sandhaus. Dr. Sandhaus is a pulmonologist at National Jewish Health in Denver, Colorado. He is a member of the OIF's Medical Advisory Council and a former board member of the OIF. We also have Dr. Sandesh Nagamani. He's the director of the Clinical Research Division of Molecular and Human Genetics at Baylor College of Medicine. And he is the newest member of the OIF's Medical Advisory Council. So we thank them both for being here today. And Dr. Sandhaus, I am going to turn it over to you.
Great. I have only a few introductory comments to make. Why is there a special teleconference and webinar for OI individuals? And I think that the reason is that there's a concern that, number one, that OI is a disease that, while it affects bones primarily, also affects the lungs, something that we've been learning more about over the last several years. And since COVID-19 is primarily a lung infection at its start, although, as I'm sure Dr. Nagamani will point out, it has effects in multiple organs. There is great concern among patients and those caring for patients with OI that there might be increased risks for OI patients. And so we want to discuss this, tell you what we know, tell you what we don't know, because everyone is still learning about this virus and the condition that it causes. And so to start out the discussion, I'm going to turn the screen over to Dr. Nagamani, who has a presentation to make that will kind of go through the basics of COVID-19 and the effects of the SARS-CoV-19 CO2 virus on individuals in general.
Thank you, Dr. Sandhaus. And I'm going to share my screen so that you must be able to see my presentation. So I hope all of you can see my screen. So first of all, I wanted to thank the OI Foundation for the opportunity to talk to all of you through this webinar. And again, as Dr. Sandhaus said, this one of the purposes of this is to provide some of the updated information to all of you regarding COVID-19 and as OI can affect the lungs, what is the current knowledge about the risks for individuals who are at a higher risk to get COVID-19. So again, just a disclaimer, this is an educational webinar, not a telehealth session. And the views here expressed by Dr. Sandhaus and myself are our personal views, and these do not represent the official positions of our institutions or any other institutional responsibilities that we may hold. So COVID-19, as all of you know, is an acronym for coronavirus disease 2019. Now, COVID-19 is a respiratory illness which is caused by a, quote, new form of coronavirus. This form of coronavirus has been previously the family of coronaviruses to which COVID-19 belongs has been previously reported. This includes the SARS virus from 2000s as well as the MERS virus, both of which did cause a respiratory illness. Now, COVID-19 has been reported from all continents except Antarctica. It is pretty much global. It's been reported from nearly most countries, and thus it has been declared a pandemic. It is a highly contagious condition that can spread from person to person. One of the important questions that patients and families have is how exactly does COVID-19 spread? There has been many inconsistencies regarding the reporting of how the disease spreads, but the current knowledge states that much of the infection occurs via droplet infection, what this means is when an infected person either coughs or sneezes, the secretions from the respiratory tract that contains the viral particles, if they land on either the eyes or the nasal mucous membranes or the mouth, then that can cause an infection in the individual on whom respiratory droplets landed. There is also some evidence that if an infected person were to cough or sneeze onto surfaces, the virus can remain active on those surfaces for a variable period of time. And if there's another individual who were to go and touch these surfaces and then touch either their eyes or their mouth or their nasal passages, then the virus can spread via that as well. So droplet infection is the primary route of spreading. Now, droplets either by coughing or sneezing typically do not travel more than 6 feet in distance, and that is why the social distancing of 6 feet has come in. However, there are anecdotal and there are anecdotal evidence that the virus can also spread by what is called aerosol, which means that when a person coughs or sneezes, the viral particles can remain suspended in air, and this contaminated air, when inhaled, can spread the virus well. The current knowledge is that the aerosol spread is less likely to be a major factor in the pandemic spread, and much of the infection is via the droplet infections. So if you were to avoid droplet infections by either practicing social distancing, a mask, and making sure you don't touch your face or near your nose or mouth, then the infection rate can go down. And there are numerous resources that have been put out by the governmental agencies, including the CDC, say what precautions can reduce the risk of infections. Now, what are the symptoms of COVID-19? I'm sure most of you are aware of this. It's highly variable, and the symptoms can range from infected individuals having no or minimal symptoms to those who have severe symptoms and death. Vast majority of infected individuals, it is estimated somewhere between 70 and 80%, suffer from what is called mild disease, which means that they don't have to be admitted to the hospital, they do not have significant lung related problems or any other organ involvement. However, in the remaining 20%, around about 10 to 15% can have a more severe form of disease that may require hospitalization and ventilator support in few. The symptoms typically develop between 2 days and 2 weeks after exposure either to a contaminated surface or to an individual with COVID. And the most common symptoms include the following. They are fever, cough, fatigue. The patients can feel tired, anorexia, or a feeling where you do not want to eat and you do not have an appetite for food, myalgia, or what you would call like a flu-like symptoms of bodily pain, and shortness of breath. Now, other than these common symptoms, COVID-19 can also cause serious illness, which is involvement of the lungs to cause pneumonia. And once your body tissues do not get enough oxygen, you may end up having many organs also being involved, including kidney failure and so on and so forth. More recently, newer manifestations of COVID-19 are being recognized. There are some neurological manifestations that have been recognized, including muscle weakness, peripheral nerve involvement, and most recently, just 2 to 3 weeks ago, there is a new emerging evidence that children who are affected with COVID, a small proportion of them can develop a severe inflammatory syndrome, which is called MIS-C, which again involves multiple inflammation that can lead to multiple organ involvement. So why should individuals with COVID-19, with OI be concerned about COVID-19? Well, this is because anybody, including individuals with OI, can develop COVID-19. Now, the CDC and the experts state that these are some of the individuals who are at increased risk for either contracting the infection or developing its complications. And these include individuals with liver disease, serious heart conditions, immune problems, older age, obesity, diabetes, kidney disease, and so forth. But one primary concern is for individuals who have chronic lung disease. And as Dr. Sandhaus said, OI is primarily involves the bone, but a fair bit of the disease morbidity also comes from its involvement of the lung, and thus individuals with OI have to be extra careful during these times. So what steps can we take to prevent infection in individuals with OI? I've put some of the measures which were discussed with you during the first webinar that the OIF had, and also many of the resources that are already available on the OIF website, these including social distancing measures, washing hands with soap and water at least 20 seconds as frequently as possible, especially when you think that you may have been in touch with surfaces that you're not comfortable with. And if soap and water is not available, please use hand sanitizers that at least contain 70% alcohol. Disinfect surfaces with Lysol spray or wipes as and when possible, though the guidance regarding this is conflicting. The CDC most recently states that this may not be that required. However, it's a good practice to do so. Teaching ourselves and our children to avoid touching their faces as much as possible. While I'm giving this as a guidance that is out there, if any of you know how to do this, please let me know, because I tried to tell my children not to do it and they started touching each other's face just to tick me off. So if you have any advice for us on that, please let me know. Ask everyone entering your home to wash their hands, and please do not be shy about telling individuals to do the right thing, in the sense that if you're uncomfortable with somebody coming home, please let them know and be an advocate for yourself, your loved ones, or your children. Now, if someone in the household were to develop signs of viral illness, as majority of individuals with COVID-19 are managed at home, you have to have systems in place so that that they're isolated within the home, and make sure they, as well as other individuals in home, wear an ear loop mask, thus reducing the risk of infection to other family members within the household. So some of the common questions regarding COVID-19 that I've had to face with patients asking are the following, and I'm sure there are many, and we will go over them during the question and answer session. But some of the ones that I thought we would just at least go over are the following. So one question is, I have pain. Can I use medications such as ibuprofen and other non-steroidal anti-inflammatory drugs? And these are abbreviated as NSAIDs. Now, the concern comes from anecdotal reports that showed that there could be potential negative effects of some of these medications, especially ibuprofen, which portended a severe disease in younger individuals who took these. Now, after those anecdotal reports, systematic data have not shown a proven risk. There are limited data about the risks for NSAIDs in the setting of COVID-19. There are no population data that prove definitive risk. So most regulatory bodies, including the EMA, the FDA, and the CDC have made no specific recommendations that NSAIDs best be avoided. But a good clinical practice would be avoid taking them for long term as far as possible. If you can take an alternative medication such as Tylenol, please try to do so. But if your physicians have recommended NSAIDs and you need them for management, please contact your physician, and there is no known contraindication at present with use of the same medications. The second question that is commonly asked is, may I travel? And since many individuals with OI travel even to get their medical care at specialized centers, this is a common question. The CDC advises refraining from non-essential travel. So make sure that when you travel, it is absolutely required. It is a no-brainer not to take cruises. I do not even know whether cruises are operational now, but there is a lot of information available on the CDC travel advisory. Please do take a look at it. And again, these slides will be made available later, so you do not have to write down the URLs, but they will be available on the slides. One question that I've had from patients who are coming in to see me or who have to go into infusion centers is, can I go to the clinic? Can I get my infusion? If I do break a bone, can I go to the ER? And what precautions do I take? So please talk to your healthcare provider to come up with a plan for these. My general approach to this is to talk to the patients. When I do feel that traveling or being at the hospital is a risk for a particular individual with OI, I tell them not to come in. I make sure that they have a virtual or telephone health visit so that their concerns can be addressed that way. Now, if you have to go in either to get an infusion or have to go into the ER, please take extra precautions, which means wear a mask. Make sure that you keep the wait time in public areas to be minimal. Some of the ERs have long wait times, so if you have to go in, if you register, please go back to your car, sit outside of the public areas, and have the ER call you as soon as they're ready to go in. One point you have to be aware of is many local hospitals have their own policies of who can accompany the individuals going in. So if you cannot drive and need a ride to go back, make sure that you're allowed to take a chaperone with you to the hospital, and what their policies actually are regarding having other individuals inside the inpatient facilities. I want to point you to some of the resources. The OIF has fantastic resources that they have developed for individuals with OI and COVID-19. Please go to the OIF website. The URL is right there. I've also listed the CDC and WHO URL so that you can go and get appropriate information from there. I just wanted to end by again saying thanks to the OIF, and I will turn the show back to Michael.
Thank you so much to both Dr. Sandhaus and Dr. Nagamani. We appreciate all that information. It sounds like there is definitely more information that we're learning, it seems like, every day. Also, I'm looking over at our chat bar, and we have lots of very good questions. We have just a few questions that we had pre-written before this that we're going to try to get to, and then we're going to go to the audience questions. So I'm going to jump right in if it's all right with you. So I guess first off is, are there any therapies that show promise in treating COVID-19?
So there are, there's only one therapy that has been approved as a potential treatment for COVID-19, and that is the remdesivir antiviral drug made by Gilead Science. And its effectiveness is relatively modest in that it seemed to reduce the time in hospital by a couple of days, 3 or 4 days. And that difference in the one study that was large enough to evaluate it was statistically significant. And there was a trend towards improved survival of hospitalized patients, but it did not reach statistical significance. So there are a large number of studies that are going on right now. And unfortunately, well-done clinical trials take time to complete because they have to enroll a large number of patients in order to be able to detect whether something is working well, as opposed to just coincidentally a patient improving when they took a pill. There are lots of combination of drug therapies. There are new therapies being developed. But right now, there's no one therapy that makes a dramatic change in the course of COVID-19 that we know of.
Great, thank you. So this is a question for both of you. And we're seeing lots of questions that kind of get at this larger issue in the chat, which is about social distancing, best practices, and lockdowns. So it seems that state lockdowns differ state by state, city by city, even county by county. What is your advice on how to approach social distancing, also obviously being with OI? And should we be going above and beyond what our local governments are saying?
Let me answer first and then turn it over to Sandesh. First of all, I don't think it's an issue of lockdown. It's an issue with this. The big change that's happening right now is the relaxing of lockdown recommendations.
Mm-hmm.
And I know that a lot of people that have been told, for instance, that they might have an increased risk of getting more severe disease due to their underlying condition. And that recommendation has been made to OI patients. So the presumption is that they consider themselves, and probably should consider themselves, in a group at higher risk of getting more severe disease if they get infected, have to take those kind of opening up orders and modify those for their own medical condition. So in other words, if a city says restaurants are open and stores are open, that doesn't mean that you have to go to crowded restaurants and crowded stores. It certainly means that if you do want to go outside, you should maintain social distancing. You wear a mask. And if you're going to be in contact with surfaces of some sort, you should probably wear gloves. We can talk in an additional question, what is the magnitude of the risk to OI patients of getting more severe disease? But I'll let Sandesh talk about his view of these newly opening and relaxing of these stay at home and social distancing orders that had been in force.
I agree with Dr. Sandhaus in the sense that now with the relaxing of some of these restrictions, we may see an increase in the number of infections. We, at least here in Texas and Houston, are seeing that. And to echo what he said, even though it may not be a legal requirement to wear masks when you venture out, given the increased risk for developing COVID-19, I would definitely recommend that individuals with OI take more precautions what the general population would, and practice at least social distancing as well as personal protection with the use of masks. An additional thing that is relevant to this is you also may ask, well, our employers are opening up and we're being asked to come in. So can we go to work? And that's a much more complicated question to answer. Most employers nowadays are allowing remote working if it is possible to do your job remotely. And if you were to require a note from the physician that you are at elevated risk, you should talk to your healthcare provider to sort of have a note which will allow you, which will serve as an exemption for you to work remotely.
Related to that also is the concern, what if someone in my immediate household is going to work because their employer has opened up and there's not a possibility of working from home, and our household finances need that income to return. And really the issue then becomes, how do they protect the family members that remain in isolation or in restricted exposure? And I think we've learned a lot from physicians and healthcare workers who have to work with COVID-19 patients. They go into a regular routine in general where they, say, enter the house through the garage, strip their clothes off before they enter the house, head to a shower, then get redressed in clean clothes before they mingle with the rest of the household. And those are the kind of plans that families have to make in those kind of situations.
Thank you. I want to talk a little bit about medical visits and how to approach them now. So you both talked about this a little bit, but how do you decide between choosing an in-person versus a virtual clinic visit?
So that a lot of that depends on whether specific studies or procedures or treatments need to be done that can only be done in a healthcare setting, and whether those procedures or studies can be delayed until we know more about the virus, its treatment, and potentially prevention. So if a telemedicine visit can be done, that's usually a situation in which you're either on a webinar like this or on a telephone with your physician, and they do a structured visit that essentially gets your medical history and that sort of information. Also, it's helpful if you have a blood pressure cuff and things like that at home, perhaps an oximeter, or whatever the physician might need to evaluate you. Then it's always, in current situations, it can be much safer to have a telemedicine visit. But if you have to go into the healthcare setting, either because you have a fracture or you have that needs to be treated, or you have a study visit that requires you have a office visit or something that requires you to go in, or because you need an infusion of a medication, then there are lots of things that can be done, and a lot of things that medical centers have done. The very first step is always to call your physician and discuss the options. If you have a medical center that's local that deals with COVID-19, it's almost a certainty that they've set up procedures to segregate patients who are there for reasons other than COVID-19, to segregate them away from patients who are either being evaluated for COVID-19 or are being treated for COVID-19. And that includes separating staff that work in COVID-19 from staff that are working with otherwise healthy patients. And it also almost always involves getting a viral test before you enter the facility, both staff and patients wearing masks, and in some cases gloves, and things along those lines. I don't know, Sandesh, do you have something to add to that?
No, I think you covered everything. And what I would add to that would be, if you do have an electives, a routine visit that you have to go just to check in with your doctor, either try to get a remote visit, like a virtual visit, or try to postpone your visit by a few weeks or months until it is safer to go in. If you have elective diagnostic procedures, I would make sure that you call your hospitals even before you go, because many radiological procedures, for example, DEXA scans were not being done at our own medical center until this week, because it was not considered, you know, a very urgent or required procedure during these times. So please don't make the trek without knowing that you have to go in. If you do not need an in-person examination-based visit, trying to do a virtual visit would be the way to go for now. And if you do have to go in, please talk to your physician and try to go in at the time of the day where the crowds are typically less. What I mean is, if you were to go early during the morning, somewhere around an 8 a.m. visit or an 8:30 a.m., it's more likely that there'll be fewer people in the clinic than around noon time. So please make sure that you discuss this with your physician while planning your visit.
Great, thank you. Are there any specific recommendations around infusions that you would give, given this context?
So the big, since I deal a lot with patients in receiving infusions, this has been a major issue for patients. There are some centers that have closed their infusion centers if patients are getting their infusions in a hospital or clinic setting. And that presents a major challenge to try to arrange those infusions to be done in the home or in the office. But even in patients who get their infusions at home, there's a concern that a home IV nurse has already seen 3 or 4 or 5 patients before they come to your home, and who knows what their exposure has been in those settings. We had one situation in which a patient, an infusion nurse came to the patient's home to give them an infusion, and the nurse casually mentioned that she had just come off a shift working in the ICU with COVID patients before heading to this person's home, and basically the patient refused to let her into their house, which I think was appropriate. So you just have to discuss with your physician and with the setting that you're having infusions in, what they do. My center, we have strict policies that forbid a nurse or physician who's working in the infusion center to have any contact with the areas of the hospital that are treating COVID-19 patients. And we have similar guidance for home infusion nurses about what they should do to maintain the safety of the patients they're infusing.
Thank you. I want to talk a little bit about, so what metrics and measures should people be keeping at home then to monitor themselves?
I don't want to start all of these.
Oh, no, please, yeah.
Sandesh,
No, go ahead, Dr. Sandhaus.
So but basically we recommend that that everyone have a thermometer and take their temperature at least once a day, and preferably in the morning and in the evening. If you can get one, get a relatively inexpensive finger oximeter and measure your oxygen saturation. It's good to get kind of a refresher from a nurse or healthcare provider on how to do that and what it means. But basically, one of the issues with people infected and developing COVID-19 is one of the first things that often happens is that their oxygen drops, but that they do not sense that lowered oxygen. And so by measuring your oximetry every day, you can be reassured that your oxygenation has not taken a tumble. And it's one of the things that winds up hospitalizing most patients is when their oxygen level drops. Even if they have minimal symptoms, they can often be admitted if they're requiring high flow oxygen when they've never required oxygen before. So those are the two tenets of, besides monitoring symptoms, it would be have a thermometer and use it. And if you can, obtain a finger oximeter and make sure your oxygen saturations are staying, if you're at sea level, above 94% or so.
That was so comprehensive. I have nothing to add to that.
Great. So I'm also seeing some questions that are sort of based around severity of type of OI and symptoms. So, like, for example, should people with type 1 or more mild OI be taking the same precautions as someone with a more severe type or showing of OI?
I think we have to preface this by saying that we have very little information from evaluating patients with OI who have gotten COVID-19 to base our recommendations on. Our recommendations are pretty much entirely based on our understanding of the fact that OI patients have are lung affected as well as bone affected, and that we know that in other conditions that where there's an underlying genetic issue with the lungs, that there seems to be a trend towards worse disease if they get COVID-19. So we're drawing that assumption that the effects on the lung of OI increase the risk that if you get COVID-19, that the disease caused by COVID-19 will be worse. But that's really an assumption, but one that takes into, it's better to err on the side of safety than err in the other direction. Having said that, it would be logical that people with milder forms of OI might have less risk of severe disease, but that's adding speculation to speculation. And so we're pretty much saying at this point, we should say OI equals likely increased risk of getting worse disease. You notice that I'm not saying increased risk of becoming infected. There's no evidence that people with underlying lung disease of any sort are more likely to be infected with COVID-19. It's really what happens to them after that infection starts, whether they go on to get more severe disease or wind up having one of the milder forms that can be treated at home.
So I think that also answers an important question that was on the chat box that was asked. The question was, does Dr. Nagamani mean to say persons with OI may have increased vulnerabilities if they get COVID-19, or do they have a higher propensity to get COVID-19? So thank you for answering that.
Great. So one thing, so for people that require nebulizers, are there best practices they should have now?
Yes, that's an important question, and one that we do have information about. The issue is that when you use a nebulizer, with each exhalation, you basically generate a dramatic efflux of droplets that could be infectious if you have COVID-19. So using a nebulizer doesn't make you more likely to get COVID-19, but should you be infected, whether you know it or not, it could spread that infection far and wide within the room and maybe even beyond the room. And that's the reason that for in the early days of treating COVID-19 infections in the hospital, we avoided using nebulizer treatments, we avoided using CPAP, we avoided using high flow oxygen for fear of infecting the healthcare personnel. Nowadays, we do all those treatments in the hospital, but we have people in a closed room with negative pressure so that those droplets don't escape from the room, or at least are dramatically reduced in terms of their escape from the room, because there's some people that need nebulizers. If you're taking a nebulizer at home and you don't have COVID-19 infection, then there's no increased risk. If you might have COVID-19 infection, if you've been exposed to COVID-19 or having symptoms that you suspect might be COVID-19, but really need to use those nebulizers, then you should do that in a closed room and don't let anyone else in that room for several hours after you've done your nebulizer treatment. Similarly, you could consider using something like an inhaler with a spacer in place of the nebulizer if that would work for you.
And Dr. Sandhaus, just to follow up on that, there are individuals with OI who are either on BiPAP or CPAP or Trilogy, respiratory requirements. What is your advice to them? Because that'll fall quite close to what you're talking about, the nebulizer therapy.
Absolutely, absolutely, and I hesitate to do something like recommend that you move to a different bedroom than your spouse or something like that, or if you're using something during the day to decrease your carbon dioxide retention, that you be in a separate room, because the vast majority of people don't have COVID-19 infection. But at the first sign of symptoms where you don't know yet whether it's COVID-19, or if you know that you have COVID-19 infections being treated at home, you really do need to isolate yourself when you're on those kinds of therapy, CPAP, BiPAP, non-invasive ventilation, things along those lines. Using supplemental oxygen by nasal cannula is probably not a risk factor for spread.
Great, thank you. So are there issues that people are dealing with after they've had COVID-19 that might affect a person with OI more? So for example, I'm thinking of like kidney or GI issues, but it could be anything, I guess.
I don't think we know that.
Mm-hmm.
What would you say, Sandesh?
I do not, I agree. I don't think we know that, but if your pulmonary, if you already do have severe OI and do have reduced pulmonary reserve, I think it would be reasonable to expect your recovery time to be a bit longer than individuals whose lung functions were to be normal to begin with.
Right.
With regards to GI, I do not know whether there's a specific question, but I did read on the chat box that one of the individuals who had COVID-19 and OI does have issues with taste, prolonged even after recovery. So is that normal? I don't think any other non-lung related issues are known to be different in the OI community versus the non-OI community. But I don't, I think the respiratory recovery would be a bit longer in those who have lung disease.
Right. The recovery from people who've had enough lung involvement to be hospitalized, once they are discharged from the hospital, it's usually, in general, it's a long recovery period. We know that patients who have acute respiratory distress syndrome, or ARDS, which is what people with COVID-19 get when that's usually the reason they're transferred to the intensive care unit and wind up on mechanical ventilation. That recovery from ARDS takes a long time. That initially the thought was that there was often permanent lung damage in patients who make it out of the hospital after having ARDS. But in a large study, it was found that after about a year, the patient's lung function has returned to where it was before their ARDS, if they survived the ARDS. And so we would expect the same to be true for OI. We don't see any reason that someone wouldn't eventually return to their normal lung function. And I would think the same might apply to other organ injury that COVID-19 can give and can cause in anyone.
Great. So now I'm going to move into some of the audience questions. So I'm seeing lots of trends emerging. We have a lot of really good questions here. The first thing I want to talk about, though, is around vaccines. We're seeing quite a few questions around vaccines. I'm going to sort of paraphrase a bunch of questions here together, but if you wouldn't mind, could you explain a little bit about how the vaccine process, like I guess the research process works, and to your knowledge, using the best information we have today, do we have any type of realistic timeline for this?
I can take an initial stab at it, and Dr. Sandhaus can weigh in as well. There are many different approaches to vaccines that are being explored. One of the ones that at least has made a bit farther than the others in the United States is an RNA-based vaccine. This is being explored by a company called Moderna. There are protein-based vaccines as well. The overall approach to this, whether it is an RNA-based, DNA-based, or a protein-based, is to be able to generate an immune response against some particular protein product of the virus. And once you have that, you'll have protective antibodies. Thus, if one were to have a vaccine response, then were to get it exposed to an individual with COVID-19, then the antibodies would be protective. So the timeline, again, for this would depend on how effective these strategies are. From the initial readings, I just read a couple of days ago that the Moderna vaccine has shown some initial promise, but it's still a few, it's a long way before it gets to demonstrating safety as well as efficacy. Now, given the circumstances, I would think that the FDA would be looking very closely at how fast they can approve a safe therapy. The timeline that has been proposed by our current administration is sometime by the end of this year, and the NIH has a goal to sort of make this a priority as well. But until this happens, I think we do not know when the vaccines will be approved. I will also add another couple of vaccine-related questions that I saw on the chat box. One of the questions was, because OI is a genetic disease, does it make it less likely that an RNA vaccine would work for individuals with OI? And the short answer to that is no. Individuals with genetic diseases do get nucleic acid, but can get nucleic acid-based vaccines, and there is no contraindications to receiving them. Dr. Sandhaus.
I have high hopes but low expectations that this is something that's going to happen very quickly. There are so many unknowns. We presume that people who develop antibodies to the coronavirus after they have been infected are immune to getting a new infection, but that's still an unanswered question. And especially we don't know, even if they are immune immediately to getting another coronavirus infection, we don't know how long that immunity will last. And the same thing will be true of a vaccine. We all have our fingers crossed. We all want to get out there and we want this to be over. We could be very pleasantly surprised and find that there's something available as soon as the end of this year. It would be a monumental effort if that were the case, and hopefully a monumental effort will be made.
Thank you. I appreciate that. Kind of going on those other vaccine questions, should we be holding off from, say, certain types of like large public places, or even sending your kids back to school in the fall until there's a vaccine? Or is this too broad of a question?
I think Dr. Sandhaus and I did answer that. It would take a monumental effort to have a vaccine that is available and production to have enough number of people immunized before the fall. And until we do have a preventative measure, social distancing and making sure that we are taking measures to prevent infection will be the most important measures to prevent contracting infection or spreading the infection.
Okay.
You know, I think there could be, you know, I think if there is, if people are sending their kids to school in the fall, I would hope that it would be a very different schooling situation than what they left in terms of, you know, keeping social distancing, having classrooms in the gym so that kids can be, you know, that far apart. It is absolutely true that kids tend to have much milder and often asymptomatic infection when they get COVID-19. But we all know, as Sandesh mentioned, about the this new syndrome that is being identified in kids. It seems to be very, very rare. And so it's hard to know what will happen with that. But, you know, I don't want to be political, but you never can tell what any particular governor or local official is going to decide to recommend for schooling. And I think you should base your decision for your kids based on the information that you'll gather between now and the fall.
Thank you.
And just to add to that, I am aware that there are I do not know of that in the United States right now, because most of the school districts here in Texas, and from what I understand elsewhere as well, have been closed for this academic year. But I have relatives who live elsewhere, and when the schooling has been opened, again, it's done in a phased manner wherein they only have one grade that goes in. The younger grades are not going in, so that those classrooms are being opened up for the same grade. And kids are being placed farther apart while they're getting instruction. And instead of having 5-day school weeks, they're having fewer days school weeks. So it's hard to speculate what will happen here in the fall and what the local authorities would decide about how schooling should occur.
And just to add another wrinkle, I mean, it's almost not just the fact that the kids are at low risk for getting severe disease from COVID, but also the fact that even if they only have mild disease, they can still bring that disease back to their entire family when they come home. Having said that, there are counties in the United States that have no COVID-19 infections, some of which have even done good testing. And so it really is going to be a locale by locale decision whether it's going to be safe for kids to go back to the schoolroom in the fall.
Great. So I wanted to ask then, actually, this question about other vaccines. So should we still take a flu vaccine if we did not get one already, or should we wait until the next version? And also, what about the pneumonia vaccine?
So the flu vaccine is winding down in many parts of our country, but if you're still in an area that has flu vaccine available and has flu in your community or your general area, then you should, and you haven't had a flu vaccine yet, you should definitely get one, and you should be first in line to get one when the new flu vaccine comes out in the fall and early winter. There is no evidence that the flu vaccine makes you more or less likely to get COVID-19, but there have been cases of people who had both COVID-19 and the flu at the same time, and they did very poorly. So you really do want to not add flu to COVID-19. In terms of pneumonia vaccine, should follow the usual guidelines for the pneumonia vaccine that has the potential to avoid some secondary infections if you were to get COVID-19, although that hasn't really been documented and looked at in a consistent way. It's reasonable to assume that the bugs that are covered by the pneumonia vaccine would have a harder time taking hold if your lungs are already injured from COVID-19.
Great, thank you. I want to move on to talking about prevention in a broader sense now. So what are best practices for preventing COVID infection that you think are most important for people with OI to consider as we figure out how to sustain the changes many of us have made over the potentially many more months? So looking forward now, we're seeing that, you know, this will not go away next week. Are there like sort of a list of the most important best practices for changes that to help prevention?
I think Sandesh can repeat what he's already said.
Mm-hmm.
I think that those are exactly the same
Okay.
practices we have said, and you know, or on the slides: social distancing and personally protecting oneself. Make sure you're vaccinated against, you know, the pneumonia as well as the flu as required, and make sure that you do not put yourself at risk situations.
And hand washing, hand washing, hand washing.
Mm-hmm.
I would particularly, again, for children as well, there is a wonderful TED Ed video, which is basically 4.5-5 minutes. I do not own stock in TED Ed. I wish I did, but I'm saying it's a very nice video on showing how hand washing and use of alcohol can impact how it destroys the virus. And once I would recommend that you show your little ones that for the hand washing importance.
And I do recommend face masks when you're outside.
Yep.
It really makes a difference, both in terms of protecting yourself from inhaling droplets and in terms of protecting others. If you happen to have a COVID-19 infection and don't know it, keeps it from spreading those droplets to others.
Actually, that brings up the next question I wanted to ask both of you. So definitely face masks have been this thing that's central in not just a conversation that the OI Foundation is trying to spread, but like the larger international conversation about stopping the spread of this. But also, like, I'm seeing more and more about the face shields. So I think about like that thing that comes over and it's a plastic screen that goes over your face. What are your thoughts or recommendations around using those, either in conjunction with a mask, or can they substitute wearing a, say, non-medical cloth mask?
So in medical practice, a face shield alone is not effective at preventing against a droplet inhalation. It does keep droplets from, you know, hitting your face, hitting your eyes, things like that. And so generally a face shield, if it's going to be used, should be used with a mask. It shouldn't be a substitute for a mask. I know that I've seen images of several countries where they have apparently more face shields around now than they have face masks, and so people are using them. And so it's probably better than not wearing anything. But a face shield plus a mask is almost as good as having a really high quality mask. You know, the issue with masks, of course, is everyone's using anything from a handkerchief to a bandana to a surgical paper mask to the higher quality, better fit, you know, N95 type masks. And the main reason that we're not recommending people use N90, this is a personal opinion of mine, the main reason we're not having everyone wear N95 masks on the street is only because we don't have enough of them, and they're being reserved for healthcare workers and critical personnel and delivery people and that sort of thing. If there was an unending supply of N95s, everyone should be in an N95 mask because the surgical type masks with the openings on the side are simply not as, don't provide as much blockage of droplets as an N95 does. Hopefully there'll be increased supplies over time and everyone can start wearing them. But in the absence of wide availability of N95 masks, a surgical mask provides a considerable protection over not wearing a mask.
Great, thank you. Can we talk about dental visits for a little bit? So obviously a related issue with OI for many people is DI, but even those without DI often may experience some increased sensitivity to dental issues. I know I personally am included in this category. Sometimes I feel like I'm getting toothaches. Should we be thinking about dental visits soon?
So again, when I have spoken to many of the dental experts as well as the surgeons, this is one of those procedures wherein the healthcare provider is pretty much in close proximity to your respiratory sort of tract. And if it is any routine dental procedures or dental cleaning that can be put off for another few weeks, it would be reasonable to postpone them. If you do have a severe dental infection or a dental abscess that require urgent care, then you have to call your dental surgeon to come up with a plan for the treatment. But I have personally been trying to tell my patients, if it's routine non-interventional dental visits, such as cleaning, these can be postponed until it is safer for you to go back.
Great, thank you. Just reading through the questions now.
I see someone's asking about how often we need pneumonia vaccines and things like that. It's pretty complicated to explain. It's something you should call your doctor about because there are 2 different pneumonia vaccines, and depending on your age, they have to be taken in a certain sequence and with a certain duration between them. So it's a little beyond what we could discuss at this teleconference.
Mm-hmm.
Dr. Sandhaus, this is Tracy. I had a question about the pulse oximeter that you talked about.
Mm-hmm.
I know that, we've had conversations in our community that your baseline might be different if you're a person with already some respiratory issues or lung issues. Can you talk to that, or
Sure.
where
Actually, the biggest difference is if you happen to live in Denver, where the normal oximetry is between 93 and 95%, and where all the guidelines about oximetry and COVID-19 say that you should report to the hospital if your saturation drops to 95%. And in addition, obviously, if there's underlying lung disease that affects your oxygenation, then it's really the drop in oxygen that you are interested in. The fact is that people who develop COVID-19 and eventually wind up in the hospital, their oxygen saturation drop is not a matter of a couple of percentage points. They often, without having a sensation of shortness of breath, they just feel some heaviness in their chest, can drop their saturations down into the low 80s, 70s, and even 60s without having a sensation of shortness of breath. And that's one of the reasons that people seem to crash when they come to the hospital, is because they've already lost so much ability to oxygenate by the time they make it to the hospital that every additional essentially loss of units in the lung that can oxygenate the blood has a much more dramatic effect. So it's a very kind of sneaky disease when people get it in their lungs, in terms of by the time someone is significantly symptomatic, they probably already had a lot going on in their lungs before they even noticed.
Thank you.
But there's the things that were mentioned can happen along with that give you the key. Like one of the most common newly appreciated complexes is, as was mentioned earlier, loss of sense of smell and loss of sense of taste, which can often precede other symptoms. So something to look at. The most common thing that people have said when I've spoken to them was, I couldn't smell the coffee in the morning.
Mm. And Michael, I know there have been a couple of questions. I know we're running out of.
Francis looks like he has a question.
Oh, okay.
Oh, Dr. Gloria, I'm going to unmute you. There you go.
Could you just want to make one comment regarding the vaccine. If you look at the story of the HIV, there was never a vaccine found that was efficient, and until they got this tritherapy and drugs. So I think that the possibility to develop drug, I'm not talking about chloroquine, of course, but on some other drugs that could be efficient is something that should be remained as a possibility and may actually be occur rapidly, we don't know, and be as efficient, if not more efficient, than a vaccine.
True. There's a large study going on now with a combination of 4 different antiviral drugs that are existing antiviral drugs to see if they might combined have an effect on the virus that causes COVID-19.
Thank you.
On that note, actually, I think I know the answer to this question, but I'm going to ask it anyway.
You could answer it if you want.
I would not dare. So the question is, what is your opinion regarding the use of hydroxychloroquine for COVID-19?
So I can take that, and then I can have Dr. Sandhaus chime in as well. Again, hydroxychloroquine has in vitro studies, which means that when you do these experiments in a culture dish, has shown some activity against the virus. However, to date, there are no valid or validated in human data that shows that this medication is active against the virus and that it will reduce the symptoms. There are many clinical trials that are ongoing, both for prophylaxis before you would get COVID-19, post-exposure prophylaxis, or as treatment for COVID-19. And there are ongoing trials. I do not recollect how many they are, but there are more than a few with the hydroxychloroquine medication. The FDA has an emergency use policy which says that this medication should be used in the context of a clinical trial. And when patients don't have access to it, there are some recommendations of how this should be done in consultation with a physician and what the responsibilities actually are. Generally speaking, most experts do recommend that this be implemented under a clinical trial scenario. Dr. Sandhaus.
Yeah, the only thing I would add is I have 2 points I would add. One is that the recommendations for the use of hydroxychloroquine by people in the upper echelons of government is starting to have an impact in terms of making it more difficult to enroll patients in clinical trials because of the desire not to be in a placebo-controlled trial where they might not get drug. And the other thing I would say is that even the studies that are ongoing are not looking at using hydroxychloroquine as a prophylactic to prevent COVID-19. They're all treatment trials looking to see if it might have some benefit in patients who've already developed COVID-19. And of course, the concern is with hydroxychloroquine, not only that it might not be effective, but it has a known problem in that it can change the timing of heart rhythms, and in people that are susceptible to that type of a change, it could actually cause cardiac arrest or arrhythmias of the heart. And so it's not necessarily a benign drug in some people.
And I think, again, to reiterate that point, some of the trials that have used it, though they were not, they didn't have so many controls, they did see that those patients who did get hydroxychloroquine may have also developed cardiac rhythm-related issues.
Great, thank you. So I wanted to ask, we have a question here. Would buying personal oxygen tanks online be a good idea? And they bring up, they commonly sell them at ski resorts. I guess as a preventative measure.
The problem with those available oxygen systems, they're either just to give you a couple of puffs of oxygen, I mean the ones that look like they're the size of an aerosol can, or they only would provide oxygen for a couple of hours. So it's not going to help, and it could actually mask symptoms that you would need to go to the hospital to see. If it's a matter of having one so you could make it to the hospital, if you're starting to go downhill, I suppose that would be okay. But I think that would be money spent that would probably not benefit you.
Great, thank you. Another one here is, so will taking vitamins help us fight COVID-19? And if so, what vitamins should we take?
Oh, that's for you, Sandesh.
So I think one of the things that has come up is, would a high dose of vitamin C prevent respiratory illness? And it's just not for COVID-19. It's been used for many of these respiratory viruses. There are no definitive data that actually do show that taking either zinc or a high dose of vitamin C either prevents infection with SARS-CoV-2 or decreases the severity of the course. It's a general practice recommendation that taking a recommended daily allowance of all vitamins is generally good, but I do not think there's any evidence out there that will show that a high dose vitamin C would prevent COVID-19.
I'd only add two things. Number one, there is among the list of studies going on in COVID-19 is a study looking at high dose vitamin C compared to placebo. So maybe we'll be surprised, but right now there's not a lot of logic to why that would work, other than Linus Pauling way back when saying that it cured the common cold. Mm-hmm. But the other thing that I would mention is one of the big things that you'll see is people suggesting to take immune boosters or things that are supposed to boost your immune response or your immune system. And even if such things actually worked, which I don't necessarily think they do, the most severe complications of COVID-19 are because of your immune system going haywire and over producing the agents that normally lead in when more regulated to an immune response, that the immune response becomes overactive and you get this what's called cytokine storm syndrome. And so even if something were good at boosting someone's immune response, perhaps that wouldn't be the best thing to take for COVID-19.
Great, thank you.
Would you agree, Sandesh?
I do, and I would, again, there are some trials ongoing with exactly what Dr. Sandhaus said, is using medications to sort of suppress certain immune mediators to see if that decreases the severity of infections in hospitalized patients. But there are a lot of, I've seen a lot of advertisements for some of these quote immune boosters. And I saw a recent ad that said that if you were to increase your probiotics because the immune system in the gut is very important, it can decrease risk. Many of these are expensive products. So please be informed before you spend a lot of money on these.
Don't we sound just like doctors?
You do.
Mhm.
Can I just really quickly, I know we're running out of time, Michael, but vitamin D, Dr. Nagamani, just normal, just what people should be taking vitamin D?
Yep.
You know, if you're vitamin D deficient, you should be taking vitamin D. Although it's not the wonder drug that people thought of 2 years ago.
Right, right.
I think on that note, actually, I think we are just about running out of time. I want to quickly just thank Dr. Sandhaus and Dr. Nagamani for joining us here today. I think I speak for everyone on this call that your expertise and your dedication to our community are so appreciated during these times. We are so glad and thankful and honored that you could join us. We know how busy you are now, and really, we're so appreciative. I wanted to also just let everyone know I just wrote a thing into the chat bar, but if you have more questions for us, you can email us at bonelink@oif.org, and we will try to get back to you as soon as we can. If you have any sort of follow-up questions for the doctors here or for us, I'll let you know. This session has been recorded, and we'll be posting it on the OIF Facebook page or YouTube, and also on the OIF website within the next few days. Thank you so much. And Tracy, I'm going to give it off to you before we close out.
No, that was great, Michael. And thank you, Dr. Sandhaus and Dr. Nagamani, so much for all of this information. We could have you on all night, I know, with lots of questions. So thank you. We so appreciate it.
My pleasure.
Thank you, and stay safe.
And thanks to everyone for joining us. Absolutely.
Yes. Thank you, everyone, and stay safe and stay healthy. Goodbye now.
Bye-bye.
Bye-bye.